And I like this one a lot, the quotation from the Cochrane database of reviews telling us that an effective intervention to enhance compliance and adherence would be as important a development as any new drug. It really tells us there's a lot of things we need to know about the existing drugs to make them work better, but we also have to look into the future. And there's just a simple diagram or algorithm which we established within our consensus group. What we think is important once a patient is on treatment, and that should be judged on the clinical activity, MRI-based activity, and then after careful education and training of the patient, decide together whether we should start therapy or not, and then have an early follow-up and frequent follow-up, particularly in the first 2 years, in order to find out whether there are side effects, if the patient is doing well, and only if there are indications that due to side effects, clinical history of relapses or quantitative examination, there is an indication of treatment failure, then one may enter again this large examination procedure and define whether treatment escalation is the right way to go. Coming back to the development of new therapies, one really has again to spend a little bit of time where the targets of MS therapy are. And with that video on in the back of your mind, you may realize there are different areas where we could interfere with the pathogenetic process. So it's within the induction phase, so within the lymphoid organs like the thymus or also the lymph nodes, where you could try to tackle the disease process. Or then, of course, you're in this migration phase where the cells are going through the bloodstream, and only if they reach the central nervous system, then they are really enemies. As long as we keep them in here, that's fine. So there is a way to interfere with the disease process during the disease induction, migratory phase, or the destruction phase, and hopefully in the future also in the regenerative phase of the disease. So there's a very easy argument telling us if we can prevent these cells to get into the central nervous system, so if we block migration, that would be a good thing in order to improve therapy. And there is actually one such drug available which particularly targets molecules which are involved in this process, which is Tysabri or natalizumab. And here's just the way how it works. So it's one of these very funny name with a map at the end. So if you have any kind of medication which has a map at this end, it's always, you recognize it just by this ending. This is a monoclonal antibody. That's why it's called MAP. And monoclonal antibodies are very specific molecules which could target certain molecules here on the surface of the immune cells. In this case, it's called alpha-4. And if you have this antibody available, it won't any longer recognize its counterpart. And this is essential for transmigration, but it will just stay in the bloodstream and then swirl around. And by using this kind of approach, which is an infusion every 4 weeks, it was achieved a reduction of the progression of the disease by 42%, relative and an absolute from 29% to 17% of patients who progressed during the disease course of 2 years. In addition to that, there was also a very profound effect on the reduction of the relapse rate by 67%. With the interference, we had figures between 30 or 33%, but this was almost doubling to that. So very effective therapy. And even in one new kind of analysis, it was addressed, the question was addressed, how many patients actually stay without any kind of disease activity? That means they don't have any relapses, no EDSS progression, no new or newly enlarging T2, and no gadolinium-enhancing lesions. And you could double this in a population who were already on Avonex, so an interferon treatment, and didn't do very well. But if you add natalizumab to that, then you could achieve this doubling effect in the amount of patients who didn't have any disease activity. So far, so good. Everyone would think that this is probably a very well-tolerated drug. It even had an effect on health-related quality of life issues. Again, we don't need to go through all these figures. It also scored positively there. But then came as a shock the notice that 3 of these patients who were on the combination therapy developed a deadly infectious diseases. And actually 2 of them died from it, and the third one survived with severe sequelae. So that means that all of a sudden we are facing with a very potent treatment, but we have a risk which is adjusted around 1 in 1,000 that severe side effects may occur. And there have been follow-up on this, of course. After it was suspended for a while, it was reintroduced, and there are worldwide now over 12,000 patients under therapy, and so far no further case of this severe disease called progressive multifocal leukoencephalopathy, or in short terms PML, hasn't occurred so far. And it tends to have still a very profound effect on the relapse rate as well as on the amount of patients who remain progression-free. So there is an issue hasn't been completely solved, but so far the ongoing data seem to indicate that there were no further cases of this severe side effect. So in summary, one could say that currently it's among the most effective therapy available, approved for treatment of MS, but with a potential risk of severe side effects. So going now on with our team of the players within the MS Treatment League, we may ask whether we could do better if we just buy a few new players and look at data which comes out of these new treatment trials. And there we can basically make the distinction about treatments which are among the monoclonal antibodies, and I've named that to you. They all have this funny MAP ending, daclizumab, rituximab, alemtuzumab, or with the oral compounds, which are the ones, and Cyril clearly pointed out, I would like to have a tablet which I could swallow once, twice, 3 times a day, or even at less frequent intervals. So these are the 2 major categories under which we group the new treatments. And I will just give you a few examples on that, not to overtake too much of my time. Again, here's something nature creates for us. So it's a kind of fungus material which came out of that with that funny formula called FTY720 or fingolimod, which again is something which basically tries to keep the cells outside of the central nervous system. It's a slightly different mechanism. It basically traps the cell in the lymphoid organ, but again the net effect is that they don't reach the brain, no inflammation going on there, supposedly a very good mechanism which should work in MS as well. And the initial data from that study did show that there is also again a reduction on MRI activity, no new lesion which occurred, and under a very short period of time, just half a year, which is regarded in a chronic lifelong disease, a short interval, this was very effective. And that basically leads to the conclusion that a large phase 3, so bigger trial program was set up, both in a way that there are trials which compare fingolimod against placebo, but also one active control trial running 2 different doses of fingolimod against Avonex beta interferon. So this is the one of the promising candidate for the future, and it's a tablet which can be swallowed, so it's an oral drug. The other one, which we will hear something more about during this meeting, is alemtuzumab, Campav. So you recognize already, oh, that's an antibody. It's called MAP at the end. What does this one do? Coming back to this figure again, there's one option to stop the cells getting into the central nervous system. The other way would be just get rid of the cells. That's what this treatment does. It is against a certain antigen on the surface of immune cells, and it just reduces the number of these immune cells. And the initial trial, which has been done, had some reports, again, of severe side effects, which we were really concerned about. On the one hand, there are certain disorders related to platelet dysfunction. So there had already been bleeding disorders, and actually one patient died of that. And then all of a sudden, a few amount of patients develop autoimmune thyroid disorders. Again, something we were worried about. But look at the effect. This one had an 80% reduction in relapse rate, 66% reduction in progression rate, and not against placebo, against an active drug, against Rebif, which right now we consider one of the very effective basic therapy we have.